I'm very happy with the ICL, and actually I had no reason to change the product. The idea to opt for the IPCL, there were two reasons. One, the range of diopters that you receive with the IPCL is bigger. So at the far ends of hyperopia and myopia, you have a greater choice. Second, I found that, or I was attracted by the idea that the toric optic of this product of the IPCL is individualized with regard to a technique where you implant the lens always on the horizontal plane. In my experience, the alignment on an oblique axis or a vertical axis or close to vertical axis is not as stable as the position in the horizontal plane in the sulcus. So I think it's for a toric posterior chamber phakic IOL, it's a good idea to have a standardized constant implantation axis. It makes the life easier, and I think the lens is more stable. The third and most attractive feature that this IPCL has is that you can correct presbyopia. And we have this group of patients, 45 to 55, with ametropia or low ametropia. And actually, whatever you offer to these patients usually is based on monovision. This is not really correcting the problem in such a way that you can promote it on a large scale, because the acceptance is not as good. It's many compromises with regard to spectacle freedom. Some patients with monovision, they need spectacles for night driving, and they need spectacles for computer work. But this is not a really good way to address presbyopia. On the other side, I'm reluctant to do a refractive lens exchange on such young patients. We know that retinal problems, other problems, they scale with age, and they scale with the amount of myopia. So the younger the patient is, the higher the myopia, the more risk is involved with regard to the retina. So having the option to correct presbyopia and ametropia at the same time with a procedure where you do not have to take out the crystalline lens, I think it's very attractive. I am aware that these patients might develop a cataract more early. We know this from the ICL. The older the patients are when you do the implantations, the higher the myopia is when you do an implantation in an older patient, the sooner the cataract will come. This is just the way it is. But I take this into my consideration. I talk with the patient, and if we can gain, let's say, 5 years with an intermediate or interim solution that postpones the need of a refractive lens exchange, I think it is worth to do it. And that's why I think that this product in this group of presbyopia patients, young presbyopic patients 45 to 55, is, if it works well, we have to see, is a really a game winner. It will be much more interesting to do this than a refractive lens exchange.